Are you able to tell us what you see at all?
Yes. So I see portions of the bone and fracture going into the spinal canal.
Yep.
So yeah, so that's in the sagittal view. And yeah, sorry, that's a sagittal lumbal sacrum T2 MRI.
Yep.
And in the axial, you might see also some compression in the spinal nerves going through the spinal roots. They're right there.
So on this axis, it's a bit tricky because you can see the canal, but I haven't showed you the foramen to comment on the exiting roots. You can comment on the traversing roots here. You can see how there's complete effacement of the canal, how there's basically no CSF signal here. But basically, the key things you want to look at on this MRI, which are going to become relevant for surgical planning, are the ligamentous anatomy. So this is the ALL coming here. And the main thing you want to see is there a focal disruption in the ALL? It's hard to tell, but the ALL actually appears intact to me. I think the ALL was just pushed anteriorly, but not completely disrupted. And so that will have important implications for surgical planning, as you'll see in a couple slides. The other important thing, like you said, is the degree of canal effacement. And so on this slice, you can see that the canal is greater than 75% effaced. And the other important thing is what ligaments are disrupted. So based on the degree of retropulsion here, presumably this PLL is completely gone. His ligamentum flavum is hard to see, but you can actually see some hematoma behind there. His ligamentum flavum is probably injured as well. And I think I have it on the next slide. Let me just go to the next slide. Better images there. So yeah, these are T1s, and you can just, you can see the fracture morphology a little bit better here. But you can see how narrow the canal here is, how there's widening through the interspinous space there. And then here you can get a better idea of the facets and how there's widening of the facets there. Presumably he's got capsule compromise. So it's essentially what we have here is a 3-column injury at this level with evidence of posterior ligamentous complex disruption. And so this is just to recap for everybody, just the anatomy of the Dennis 3-column model of the spine. And so in Dr. Dennis's paper from a while ago now, I think it's 40 or 50 years ago, and basically the spine is split up into 3 columns for structural integrity, and the anterior, middle, and posterior columns are what he used in his paper. The anterior column is defined as extending from the ALL to the mid portion of the vertebral body through the annulus there. And then essentially everything that's posterior from that point up until the PLL comprises a middle column. Everything posterior to PLL comprises the posterior column, if that makes sense. That's what's shaded in blue here. The PLC that JP was talking for the TLIC score comprises 4 specific components, and these have deemed to be of the most important structural integrity providing for the posterior column. And so that's the ligamentum flavum, which you can kind of see there, and the interspinous ligament here, the facet capsule, which you see at the bottom here, and the supraspinous ligament here. So if we go back to this patient's MR, go back to here, and so you can see there's T2 signal change within the interspinous ligament. Hard to assess the supraspinous ligament, but you can see at the top of L3, L4, the supraspinous ligament injury there. The PLL is presumably completely disrupted there. The main ligament that is likely intact in this patient is the ALL. If anybody had any other comments about the fracture morphology or anything.
No, I was just gonna comment for Carlos at the beginning when you put the CT scan, and this is very important right there. I think that you did a good job at the beginning describing that it was a fracture. You thought it was L5, it turns out to be L4, but to me what is more important, and if I am listening to this in the middle of the night, one of your consultants you're attending, they're gonna wanna know several things. And I think that Christian illustrated what is the exam, strength, and also some of the, lower function of the cranial, of the lumbosacral nerves, i.e. the bulbar cavernosus, the sphincter. And those are actually not very difficult things to test, by the way. When you have a patient that is in shock, you'll be surprised. Things are very loose and they have no feeling, no sensation, and it's very easy to test. So the next thing that I would want to know is what is the compromise of the canal? And this is probably where you fail. And I think that Christian was trying to get to you. If you look at the sagittal on the CT scan, you'll see that there's retropulsion of fragment and the canal is completely compromised. So those are the kind of simple little things that a consultant is going to want to hear right away. I always, I train at a level 1 trauma center, obviously, and they, Mitchberger, Maimater, everybody, they knew, they wanted to know within, 3 seconds whether or not they needed to get out of bed and come into the hospital to operate. And those are the quick things that you need to know. So I think that the important things, I think this case is a very illustrative case of principles of trauma. And I thank you, Krishnan, for presenting. But small little things that make a huge difference as you're presenting a case.
Yes, sir. And just on Dr. Q's point, Carlos, let's say you're the resident on, you got to call Dr. Bodie about this at 1 o'clock in the morning. So you say, hi, sir, I've got a 20-year-old male status post head-on collision. He's got this complete AO type 4 burst fracture with substantial retropulsion, appears to be incomplete, Asia B on examination. The other thing, after you say that sentence, you need to add is the extent of his other injuries. So if Dr. Bodie says, okay, book him for the OR, then you say, well, sir, he's actually hemodynamically unstable. He's actually got multiple X-fixes. He's actually needing to go to the angio suite because his blood pressure is 60 on 40. So those are the other factors you have to tell Dr. Bodie as well. Because right now, this patient, though obviously operative, given these images and exam findings, is unfortunately not stable for us to take him to the OR. Professor Montezer has a question.
Thank you, Krishnan, for such a very interesting piece, and thank you, Dr. Q, for the comments. Back to the CT scan, actually talking about the other injuries, it drew my attention that 2 things. One, his bladder is distended, so this is something that you need to keep in mind, as well as a large air bubble, sort of like in the midline. It shouldn't be the fundic air bubble, so I would be wondering if there's any bowel perforations or any abdominal injury, given the in a trauma setting, if you have a thoracolumbar fractures or injuries, you would always like to rule out any abdominal trauma. So that goes along with the hemodynamic instability as well.
Yep. So he was retaining urine, like Ala was saying. He didn't actually have a bladder or urethral injury, but he had high-grade liver and splenic lax. And so that was compromised. So you can see here, this is the bottom aspect of his liver. It's hypodense up there, and this is all air there, essentially. And so going back to this, so this is the AL classification just illustrated here. And so like I was saying, there's basically 3 types of injuries, and one is the compression type, that's type A. Type B is the distraction type, and type C is translational. And so this is an AO type A4. So like I was saying, the definition of a burst fracture is involvement of the posterior wall of the vertebral body, and the differentiation between an incomplete and a complete burst fracture is that a complete burst fracture involves both the superior and inferior end plates based on this classification. Again, this classification was created much more for academic purposes, for use in retrospective studies and prospective studies. When I was at PGY2, Bill Clifton used to hammer this into us, so I learned it, and he would always make us, when we messaged him about consults, use this classification. But practically speaking, the main important things for this case are that it's a complete burst fracture. There doesn't appear to be any translation, which is important as well. So it's not really a true, there's no evidence of anterior column compromise necessarily. However, that fragment is substantially displaced anteriorly. So this will become important for surgical planning. And Dr. Q put a comment. Was there, if some of the international professors were on from Columbia, if the attendings had any comments on the fracture?
I think Dr. Hakim, go ahead, please. Is that Dr. Hakim?
Yes, that's me.
Yeah, Fernando, go ahead, please comment on this, because these are things probably that you guys also commonly see.
Yeah, we see these type of fractures very common here in Colombia. The way we treat this in our hospital since 30 years ago, so we don't have problems with orthopedic and neurosurgery, is that orthopedics are the ones that fuse the patients. They are the ones that do the arthrodesis, and neurosurgery is the one who decompresses the canal if it's compromised. In this case, I obviously think you operated the patient. what I think, I'm not the expert in arthrodesis, as I told you, because orthopedics are the ones that do it. But what I think they should do is put the transpedicular screws and do distraction. And probably if there is a lot of compression, we would need to decompress the posterior part of L5. I quite didn't understand the neurological status of the patient. Does he move his legs or he doesn't move his legs? I didn't understand. His Frankel is that part I didn't quite get.
I apologize for the confusion. So his distal extremity exam was limited by the presence of X-fixes. So his orthopedic injuries limited the fact that he couldn't move his distal extremities because they were fixed in place. But proximally, he was anti-gravity to bilateral hip flexion.
Okay, so that's what we would go in. This patient definitely needs surgery. I would like to see how you ended up operating this patient.
Yes, sir.
Those are okay. Thank you.
Thank you, sir. And so, as Professor Hakim was mentioning, those are the things we discussed.
Can I just ask you one thing very quickly, Krishna? Here, it's more like about the pre-op exams, and so, I mean, of course, you're showing us a case that is in a setting of multiple level injuries, right? So a polytrauma case that is hemodynamically unstable. So I understand that you couldn't go straight ahead to the OR because of that. But I mean, at least when I was in residency, with that CT scan that you showed, quite often we would consider treatment, if patient is stable, of course, without the need of an MRI. And then I remember that at that time, there was a lot of discussion about if we should routinely do MRIs or not, so on and so forth. Can you just educate me about that in a setting like this? I mean, would the MRI change your treatment plan on this specific case or not?
So the main reason for getting the MRI was to see if the ALL was completely disrupted and to see if there was any PLL left. And I have a slide on the surgical approaches. The reason for getting the MRI in this patient specifically was to differentiate whether this could be distracted by simple ligamentaxis, like Dr. Hakim was saying. And unfortunately, this couldn't be done because that requires some semblance of an intact PLL where you distract across the pedicle screws and allow the fragments to push back. But they're pushing back against intact PLL. So the PLL was seemingly violated. We wanted to see if the ALL was preserved, to see if this patient would be a candidate for corpectomy. You know, this is a younger patient that, you know, we want to prevent from developing subsequent deformity if we can down the line. Having said that, a corpectomy is a substantial undertaking, and L4 corpectomy particularly not an easy approach by any means, which I'll discuss later in the slides. And this patient had already lost substantial blood from the liver and splenic injuries. And so that was the logic in getting the MRI. The final thing was that at the trauma hospital, getting an MRI is very straightforward. I mean, if you order an MRI stat, it's done very quickly. So it's not like there was really any particular delay in care with getting the MRI as well.
Okay, thank you.
Sure. And so you see here, these are some of the things we considered. So observation, of course, not appropriate for this patient. Dr. Gabriel, Dr. Vargas has a question, sir.
No, just a comment. It's difficult when you are in emergency situations. And of course, in Colombia, we have a lot of these kind of things. But before you take the patient to the surgery, in these cases, these patients are very unstable hemodynamic. And when you have a cauda equina trauma like this, maybe your patient is going to recover. And the studies are not clear if you should go very an ultra emergency surgery, or you wait a little bit and really wait until the patient is ready to the surgery that you're going to do, that is a huge surgery. Not even if you go by posterior, for example, the purpose of that surgery is decompress the cauda equina at the first step and then stabilize the spine. Maybe in this kind of patient, very lower lumbar trauma, L4 or 5, by posterior is more easy that go by anterior and do an anterior approach and try to do a decompression and corpectomy. we always think this kind of situation as a share. You know, you divide it in anterior and posterior. So if you damage the anterior part, you should maybe by theoretical situation should go by anterior, but this is not easy on lumbar spine, lower lumbar spine. Of course you can do it, but I think that for this case, the best thing that you can do is by posterior approach laminectomy, try to do like a posterolateral approach in order to take out the fragments and put some two short fixation, one level above, one level below transpedicular approach, and then you can see after time if you need more fixation, maybe do something by anterior approach, but later on. That's my opinion. Thank you.
Yes, sir. And that's exactly what we did. That was a discussion that was had. You know, if you take away his other injuries, and this was an isolated L4 burst fracture with that exam, then of course we wouldn't have delayed. If this patient came in at 1 o'clock in the morning, we'd be taking them in a 20-year-old with essentially an incomplete spinal cord injury. Unfortunately, his hemodynamics didn't allow us to do that. These are the surgical options we've considered. So essentially it came down to, are we going to offer a corpectomy, yes or no? And if we do, are we going to go, whatever we do, are we going to go anterior? Are we going to do anterior and posterior, just posterior? The reason that we didn't think that a corpectomy was going to be necessary in him was the previously mentioned findings on MRI that the ALL appeared to be relatively intact, and it seemed like that fragment was just pushing up. And secondly, this patient had already experienced substantial blood loss. We didn't think subjecting him to a corpectomy at L4 with probably more than 1.5 liters of blood loss was going to help him. And thirdly, accessibility. Getting down to L4 would have required the presence of an access surgeon. We would have had to ask a trauma surgeon / vascular surgeon to help us get access to a retroperitoneal approach for an L4 corpectomy. And had we done that, we would still be likely backing him up posteriorly, given the degree of retropulsion and decompressing him. And so the decision that we decided for was, as Dr. Vargas was saying, we approached this solely posterior. Given the fact that this was transitional, we decided to go for a longer segment fusion than just one up, one down. We weren't, if you can, it's hard to see, but if you go back to the CT, this fracture is completely comminuted and extending into the contralateral pedicle, actually on the left side. And so because of that, there was no vertebral body, definitely on the left side, but also on the right side to be able to get pedicle fixation through. So that level would have to be skipped. And so we ended up deciding to go for a longer segment construct, 2 up, 2 down, essentially. And we thought that we could try and see if ligamentataxis works, but we weren't optimistic on this. So we planned that we would have to use essentially a curette to reach around from ventrally and decompress the canal, try and reduce those fragments and get that retropulse fragment back anteriorly. And so that's what we ended up doing. And so these are the indications overall for considering surgery in these type of patients: greater than 40% canal compromise, kyphotic deformity, and loss of vertebral height greater than 50% or more. Rodrigo, did you have any comments?
Yeah, I can tell you. So basically the indications for surgery in these cases are neurological compromise more than anything. This is a very, as you pointed out, this is a very complex procedure if you attempt to restore alignment, because it's the base of the spine. Definitely you will need to do it. Ideally, you have to do it in an elective setting. But yeah, from these indications from surgery, this slide, I think that the first one is the most important one. The other two are just subjective. They don't really drive the surgical decision. In combination, they do though.
Sure. And so as Rodrigo was saying, these were the goals of our surgery. We wanted he's 20 years old. We wanted to see if we can give him some semblance of motion preserving surgery. But the main goal, of course, is to decompress the thecal sac, the exiting roots, traversing roots, to provide some semblance of return of neurological function, as well as provide fixation to stabilize the spine where we could. And so this was done posteriorly. So we positioned him prone on a Jackson table. we did this case with neuromonitoring. Unfortunately, due to the hemodynamic instability and the fact that he had X-fixes on, we had to actually wait 1 extra day before doing the surgery because the patient was taken in the middle of the night with ortho for X-fixes, so he couldn't be flipped prone. He had external fixations on his bilateral femurs and tibias. So the next day, ortho placed rods within his bilateral femurs, and so we were able to safely flip him prone. If you can imagine, those X-fixes stick out, you know, maybe 20, 30 centimeters off from their skin. So it's impossible to flip them prone if they have proximal X-fixes. If they have distal X-fixes, it's fine. We ended up pre-flip his neuro monitoring signals that we got were reduced as expected on that right side in the motors, but his sensories actually were preserved, and these didn't change when we flipped him onto the table. What we ended up doing is we actually started by harvesting iliac crest to maximize his arthrodesis, and then we instrumented him 2 up, 2 downs. We did 2 L2, L3, skipped the fracture level, and went L5, S1. And then what we ended up doing was trying to see if we could distract across that fracture level. As Dr. Vargas already said, that fragment was very large, so ligament ataxis wasn't going to work, but we thought we'd just give it a shot to see if we could. And unsurprisingly, it didn't work. We then proceeded to begin with the laminectomy at L4, but essentially the fracture had split right through up the spinous process of L4 and bisected the lamina. So most of the lamina was done. As soon as we removed the bone and then we started to dissect the ligamentum flavum, there was CSF egress from a large vertical durotomy, and you could see that the cauda equina roots were all sticking out. All the dorsal roots had herniated out. And so we ended up, essentially at that point became more of a microsurgical case. So it was a good case to see as a PGY4. So we meticulously dissected the roots around and were able to return them back into the thecal sac. Thankfully, it didn't seem that there was actually a ventral CSF leak, so that's what we were most concerned about. It seemed like the only area of compromise was from one of the sharp shards of the undersurface of the lamina that had just gone right into the thecal sac and then sheared it across. We ended up, after we instrumented him, like I said, we performed essentially a gill laminectomy, and so we were able to decompress the bilateral foramens. Rodrigo, you had a question, looks like.
Yeah, I was just gonna say that what you just said is perfect. I just want to compliment. So when you have these kind of fractures like A3, A4, you have fracture of the lamina. This is a very important thing to consider, because if you're in the other setting, if the patients are intact, you have to question yourself if you need to do anything like urgently because of this, what you just described. When you open the surgical site and the lamina, most probably you will have a CSF leak with all the nerves around there. So if the patients are intact and these levels like L1 and below, when you only have nerves, I think the question is, should you attempt to do anything urgently? You most probably will cause another injury, you know? So that's just what I want to say.
Very good point. And so basically after the bilateral gill laminectomies were completed, we dissected ventrally and freed up the ventral surface of the roots. The right root in particular, the right exiting root, appeared to be compromised at the epineurium level, but the endoneurium appeared intact, so we didn't attempt any primary repair. There was a marked amount of ventral epidural hematoma that we noted, and we evacuated that. And actually, when we were doing our iliac crest graft, he had a large amount of sacral hematoma because he had this large iliopsoas hematoma. He was probably bleeding into that from his femoral fracture, so that blood had accumulated. There was about 200 cc's of blood that was evacuated when we did that. And so then we carefully used curettes to tamp back the fracture fragments. As you can see from the CT scan, unfortunately, the fracture was completely comminuted, so it was this meticulous dissection, given the fact that we already had the roots exposed there. And so those were protected with the cottonoid. After we had tamped them, then we later came back to the durotomy. Thankfully, the dura wasn't completely shredded. It was actually almost a perfect linear durotomy like you would do if you were opening the dura for a case. And so we just closed that primarily with the fluoroneuralon. And at the end of the case, the motors were actually unchanged. So we didn't lose anything. Everything was as baseline. And from there, we arthrodesed, placed our rods, and then closed. And so this is a cartoon just to illustrate the concept of distraction across. So you see this burst fracture here. This is higher up in the lumbar spine. This is probably like L1. But once you instrument, then you basically distract across. and then you try and move the fragment anteriorly with that distraction and generating lordosis. And as was previously pointed out, this was of minimal benefit in this case, just given the fact that that fragment was so large and comminuted. And on the right, you see how we used a curette. So a curette is dissected underneath the ventral thecal sac, ventral to the root. And then once there, we gently used a mallet to tamp back that retropulse fragment. So this was done from the disc space above to the disc space below on both sides, right and left. And in this picture, they're doing this prior to instrumenting, and we of course instrumented first and then did this. So these are intra-op O-arm spins. Thankfully, we have O-arm readily available here. There's only one O-arm, but we were the only ones using it that day. And so the left is the preoperative O-arm spin. You can see the fracture there. And on the middle and the far right, you can see the post-reduction. So you can see how we were able to get this fragment back. There is some degree of anterolisthesis from that fragment anteriorly, but like I said, the intact nature of the ALL made us pretty confident that this would stay as is. And this is the instrumentation that you see here going up. And you can see on the coronals how this is reduced as well. Rodrigo?
Yeah, I think this is well done. You know, I have nothing to say. Every surgeon decides differently. I have a very similar case with a patient that was unstable as well. We didn't know his exam. He was in alcohol withdrawal. He tried to jump from a bridge, and he had a fracture similar to this. So my rationale on that guy is like, we didn't have an exam, and whenever he was waking up, he was just moving more and more, and I didn't know if he was going to hurt himself and causing more compression. So it was not a reliable exam. I just knew that he was moving and I had to do something. So I did short. In this case, I think the long segment above is good. The short segment up below, I would have probably anchor in the iliac or SI2 or S2 iliac, because you know those screws at S1, unless you go bicortical, they could be stronger. But other than that, they are considered weak screws.
We thought about that. We actually did go bicortical at S1, and he actually had, I don't know if you caught it earlier, but he had sacralized L5. So we were treating S1, in fact, like an iliac fixation. But we had considered taking him down to the pelvis and putting in S2 alar screws as well.
Yeah, that's the only point. Very good.
So these are his postoperative films here. These screws are more anatomic than parallel to the end plate, straightforward as Dr. Abodi or other attendings like them. But you can see the 2 up, 2 down construct. You can see that he's still anterolisthesed at the fracture site. But overall, you know, we were relatively pleased given the degree of reduction that we were able to obtain with this. Postoperatively, so we placed drains in, of course, and we left them to half suction given the fact that there was an intraoperative traumatic durotomy. We removed these on post-op day 4. He was kept intubated and subsequently ended up getting trached post-operative day 6 from this. Immediately post-op, he had some return of his function. So orthopedics internalized his X-fixes on post-operative day 2. So we were able to get a more discrete neurological exam. And he was almost anti-gravity to the L4 through S1 innervated muscles to EHL, tibialis anterior, and gastroc. Unfortunately, his urinary dysfunction has persisted. So he's still requiring straight catheterization. He has no sensation of urge and remains essentially incontinent if he wasn't for catheterization. The other thing is because of pain from his comminuted tibial fracture, he's actually about to undergo a BKA for his right lower extremity. And so he's got several other issues apart from that. But overall, from our perspective, I think we were able to achieve satisfactory decompression. I just have some slides on approaches for L4 corpectomy. JP, if you want me to stop, it's already 7:40, or could go on.
I think that maybe we can skip that for today, Krishna, just because it's already 7:40, and then we can go ahead to the next case. But maybe you can share with the team maybe your presentation, and so we can incorporate, because those are important points for review. Sure. Very nice presentation. I think very, very nice review of spine trauma cases. At least during my training, that was the kind of like the most heavy duty kind of part of spine training for many of us, and it's nice to review some of those concepts. Thank you. Very nice presentation.
Thank you.
And thanks, Dr. Vargas, Dr. Hakim, and Dr. Navarro for the comments. Kind of like for me as a brain surgeon, it's always good to review and learn some of those comments. I appreciate it. And of course, thanks, Ala, as well. Dr. Hakim, you have a comment.
Thank you.
Yes, 10 seconds. I'm sorry, 10 seconds.
Mhm.
Remember that in spine surgery, you can only do two things: decompress or fixate the patient. When you approach one of these patients, you have to think like that. Do I have to decompress? Do I have to fixate? There's nothing else you can do in the spine surgery. I remember that when I was in the Mass General in Boston, Dr. Borges, he was the spine surgeon. He said that comment one day in one of the surgeries, and I've never forgotten that. You can only decompress or you can only fixate. So when you approach one of these patients, that's the first approach you have to do. That's my only comment I have. Thank you.
Thank you, Dr. Hakim. Appreciate that. And then with that, we go to the next case with Dr. Ramos Fresnedo. Andres, please.